एंड एम्स के अंडर ग्रेजुएट होना जिसमें सिर्फ 40 सीटें होती हैं. Sir is one of those MBBS from AIMS. Then he continued into ophthalmology at AIMS. He headed the department and आपको पता है पराशर सर बंगाल में किसकी जीत हुई है? इवेंचुअली किसकी हुई है? मोदी जी की ना. उनकी दोनों आँख की सर्जरी किसने करी है? सर पर जस्ट सही कि वो है. और अभी हमारी एक ऑल इंडिया ऑफ्थेल्मिक आई की सबसे बड़ी सोसाइटी है पूरे इंडिया की. और सर अभी मार्च में उसके प्रेसिडेंट बने. सो दैट इज समथिंग. मेन थिंग इज अभी सर जो वीडियो दिखाने वाले हैं आपको, इसमें सारा खेल कैटरैक्ट सर्जरी में लेफ्ट हैंड का होता है, नॉट द राइट हैंड. ही इज अ राइट हैंडर. लेफ्ट हैंड की स्टेबिलिटी पूरे इंडिया में अगर किसी की है तो वो सर की है. एंड दैट इज व्हाई हिज रिजल्ट्स आर फ्लॉलेस. सर ये आप ही ने हमको सिखाया है एम्स में आपकी सेंटर. एंड दिस इज अ फैक्ट. मोस्ट स्टेबल लेफ्ट हैंड you will see is Dr. Titiyal's. And Puneet has just recently, Puneet तो चला गया लग रहा है. Anyway, sir आप बोल देना उसके बाद में. So sir, over to you. And I requested sir to show more videos rather than the text, so that sir बहुत से लोग cataract surgery के लिए ready हैं यहाँ पे, and most likely they'll all be your patients in the next 2 or 3 months. Thank you, sir.
Thank you, Deven, for such a nice introduction.
Decorum, please. Decorum.
I think you can hear me, no?
Yes, sir.
Yeah. Thank you so much, and good evening, friends. Like as Deven talked about, showing some of the videos, because I consider, things have changed so much. The medical science is advancing so rapidly. The technology, the input of various literature, which is scientific, which is clinical, which is making things so simpler for people to understand. And now the Google, ChatGPT is making life more difficult for us. It's not making life simpler, it's making life difficult for all of us. Thank you again for this wonderful invitation. And I'd like to thank our marketing team for managing this interaction today. Refractive surgery, anything which can correct your refractive error, is definitely a life-changing procedure. It changes your life. How you see, how you perceive, totally changes after these procedures. So therefore, I'm going to take you through the 2 important surgical devices which is used to get this refractive surgery done in a human eye. One is along with the cataract surgery. We call now cataract surgery not simple cataract surgery, which we earlier used to think. Just take over the cataract and patient will see better. Now we talk about refractive cataract surgery. We want to correct the refractive error to the minimum possible after doing cataract surgery also. And second is for young people, the young adults, where we are correcting their refractive error by various laser procedures or a lens which can be implanted inside. So these 3 important areas I want to touch you for your information today. Cataract, you all know, is the largest cause of blindness and visual impairment in our country. If you see our survey which is done, published in 2019 by Government of India, done by our center, Office Center AIMS, almost 65% people are blind because of cataract. Blind, I'm not talking about visual impairment. And visual acuity less than 6/60. So that is a huge number. Age group more than 50 years. But if you're less than 50 years, cataract is not number 1. Number 1 is a corneal deformity, corneal problems. Of that, the refractive error is the largest one. So it's a huge significant area. Now I'm going to show you 2 surgical aspects of cataract surgery which modified our approach. One is phacoemulsification, which commonly people say micro-incision cataract surgery. Because earlier cataract surgery used to be a large incision surgery. I remember my teachers, they used to say, make an incision larger than what you think, so that the entire lens can come out easily without it getting broken inside the eye or it getting dropped inside the eye. So they used to say, make the incision larger than what you think, so that you are safe. Today, we talk about make the incision as small as possible, and things have changed so much. We started cataract surgery in previous century. There were no sutures earlier. In early 1900, there were no sutures. So surgery used to be sutureless. Today, in 21st century, the surgery again is sutureless. So this is the change which happens, and concept keeps changing there also. The second important thing which is added is the laser-assisted cataract surgery. Some people say it's a robotic surgery. Actually, that's a misnomer. It's not. No robotic arm is there. It is the computerized, software-assisted laser application, so things become precise. So these two surgery I'm going to show you to your convenience today. So this is first surgery, a simple phacoemulsification where a machine, which is called phacoemulsifier, is going to emulsify the nucleus inside the eye, so that your incision gets smaller. That's why its name goes micro-incision cataract surgery. And it has a various parameters. You can see here, it has the pressure inside the eye during your surgery maintained, so there is less fluctuation. You have to have aspiration because things have to be aspirated out, which is being emulsified inside the eye, nucleus, and the cortical fiber. And for aspiration, you require a vacuum. So these are three important parameters which are there in a phacoemulsifier, the machine. And the energy used for emulsifying this nucleus inside the eye is basically either longitudinal energy or torsional energy. The tip which is emulsifying moves in a speed, which is the ultrasonic speed, almost 30 to 40,000 speed is there per second. So that is how you can't see the movement, but it's doing inside. It's an ultrasonic speed. So some people say it's ultrasonic energy. It's a speed which is there. So I'll just show you this video. This is the cataract, which is, you can see a nice glow, which is called red to illumination glow. And first thing is, making the opening in the lens. So that is anterior capsular opening. So that's actually gateway to doing a completion of a surgery and implanting lens inside the bag. So this is a circular opening I have made. Then I'm injecting fluid to make this nucleus free from the capsular bag so that it can be emulsified without damaging the capsular bag. So this is the phacoemulsifier. This is a handpiece which has the tip, and this is the tip which moves inside the eye, so it breaks the nucleus. And you can see here, I have a right hand is the emulsifier and second is the chopper, which chops the nucleus in two halves. You saw that we had two chop being done. So this is the chop which has been done. Now rotate the nucleus, make chopper. The saying goes, if you do anything, you have to divide into multiple places. So this is what we are doing. We're dividing the single force into multiple small pieces so that can be taken out very easily. So that is what we have done here. So entire nucleus is being emulsified inside the eye, and this incision is hardly 2 millimeters, 2.2 millimeters, so small. And
sir, can I just
sure.
ये जो sir के right hand का instrument है, this one, the longer one, it's hardly being used. This is giving the ultrasound energy, but he's hardly delivering ultrasound. It's only the left hand which is doing the trick. That is why the results are so good. The cornea is shiny, and there is hardly any inflammation. Sir, please continue.
Okay. So this is almost over. I'll show the next video, which is another innovation which happened in the cataract surgery. You all physicians know the CT scan, the tomography. The same thing is applicable to eye also. We do a lot of OCT, that is ocular coherent tomography, mainly used for retinal imaging, like optical coherent tomography. So what we used to have, we used to read those Gray's Anatomy and 10 layers of retina. That's usually imagination only, because that usually a histopathological section. Today, optical, you can see those areas. So this has been translated to other areas also. You can do an entire section of the eye. You can see the entire layers of cornea. You can see the lens. You can see the retina. In fact, all the structure can be seen very minutely also. So this is the first time this OCT is incorporated into microscope also. So during the surgery, you can see the section of eye and you know what you are doing. And that came to India in 2013 and AIMS was the first to procure that. In fact, most of my work subsequently is with the OCT attached to the microscope. I'm going to show this surgery for you people. So this is one of the difficult cases. So if I go back a little bit. Sorry. So this is what the OCT picture is concerned. I'll show some other pictures also. You can see this is the cataract. This is just a two-dimensional picture. I can't see what is in section here. You can just see the superficial area. But if you see the OCT picture, it gives you a three-dimensional picture. You can see because this can be this way, this can be this way also. So I can see the entire depth of a nucleus here, this part. So this part is seen like this, which is towards the posterior capsule. The entire posterior capsule of the lens can also be seen. So this gives you an idea what is happening during the surgery also. And these innovative incorporation into a microscope makes things simpler. So this is the same step. I've made an opening in the anterior capsule. This opening is around 4.5 to 5 millimeter. Because the intraocular lens optics is around 6 millimeter. So it will be fitted inside the eye. You can see the entire thing which is happening here. Separation of a nucleus from the cortex. I can see what is happening during my surgery. In a difficult situation, this becomes a real handy to save the eye from a complications. And save the eye, a chopping of the nucleus here with my second instrument. And surgery becomes very, very simple. And this is the screen which tells you, you can see both the things together. Unlike if you see through the microscope, sometimes you only see the ocular picture only, you can't see the entire OCT and surgical area also. The entire cortex is being taken off now, which is will be taken out with the section only, because once you take out the nucleus, which requires the energy to emulsify, for the rest of the cortical fibers you don't require energy. It's just a suction by which you can take out the entire cortex here. And this picture will show that the thin layer, which is posterior capsule, is intact. This is a thin layer which is seen in the posterior capsule. There is no defect in the posterior capsule. So one of the major challenges for us during this surgery is not to damage the posterior capsule. Otherwise, you can't implant the lens, and things become very difficult. This is the compartmentalization. Like posterior vitreous cavity and anterior chamber should be separate. And this capsule, you can see this is my lens, and this is the posterior capsule. So this division is safeguards the complication of future. If you lose this barrier, the entire vitreous keeps moving, and you have a lot of complication coming in from the retina point of view. So this OCT has been a real game changer for a cataract surgery patients also. So these are two micro-incision cataract surgery. The second part I talked about was the laser-assisted cataract surgery. What is the advantage of laser in these cases? Why you add extra money to cataract surgery? It gives you 2 or 3 very important things. It makes some of the steps very precise. You saw my manual surgery was also very precise. In laser surgery, what we do here, the opening in the anterior capsule becomes very precise. Circular, center, of a size, whatever you want. So that can be achieved by laser. It's totally computerized. Similarly, you can also make the chop in the nucleus so that nucleus becomes softer. This is the nucleus you can see here. So this amount of nucleus, I'll make it softer. Similarly, this is the cornea. I can make my incisions accurately of same size. Designs can also be modified. Now with a blade, you can have a single plane incision. With a laser, you can make a multi-plane, tri-plane incision, which is much more safer and less induction of astigmatism. So this is how it is being planned. So you can do a very nice incision without use of blades, and also precise steps of opening anterior capsule, and subsequently doing the fragmentation nucleus. The opening in the capsule is called capsulotomy, and fragmentation can be done, corneal incisions, everything can be done without use of blades here. So this is how the surgery goes in this particular case. So this is the small, you can say, application which go to the laser head. This is the application cone which will touch the eye. You can say it is going towards the cornea. It will just apply the entire cornea here. You can see it is applicating now. This is the applicator. Once it applicates, you can see the OCT picture. You can see OCT, you can see the cornea, iris. This is pupillary dilated, the lens. I can already done the fragmentation. This is the corneal incisions. Everything is done within a fraction of few minutes. And it's very, very fast. So that is how laser application makes things simpler for us. So there are various other applicators for doing laser procedure. This is after I've done the laser, I've shifted to patient room my operating microscope now. And you can see here, this was the main incision 2 millimeter, done by laser only. It can be opened very easily now with any incision opening devices. And this will go on till I complete the surgery in this particular case. So it's been opened now. The capsule is pre-cut, so it's a free floating, which I can just take out by any instrument there. So this is a small solution which is called viscoelastic device, which is being injected inside, which maintains the space during your surgery and protects the endothelium. You all understand endothelium is the most critical layer of cells which maintains the clarity of cornea. So that has to be saved during surgery. So this is I just pinch the capsule and I can take it out now. I didn't have to do manual rotation cutting of the capsule. So things become very, very simple. You can see these are fragmentations, which is made multiple pieces fragmentation. These ranges from a 200 micron square to a 350 micron square pieces, and that can be taken out very effectively after laser surgery also. You can see that this is what just fast forwarded. It becomes so simple to take out this already fragmented, softened nucleus in this surgery. The surgical time decreases by almost 40%, and the energy used during the surgery decreases by 50%. So less the energy, less the heat generation, less the inflammation, less is the damage to surrounding ocular structures. Because the reflection is not during the surgery. Reflection the next day when you have inflammation in the cornea, in the eye, which can be saved per se. The femtosecond laser is a very good device for difficult cases. Like this is a difficult case, wide intumescent cataract, where the cataract has advanced so much you can't see anything here. In such cases, laser application very simple. Manual surgery becomes very tough in these cases. During the COVID time, we couldn't do any surgeries. And after COVID was over, we kept seeing these type of cases, wide cataracts, which was difficult to perform surgery. The laser was very handy in these cases, and surgery could be completed very effectively in these cases also. The other important area for many people say, which is the most difficult cataract you think, clinically. And as far as we are concerned, the one type of cataract is called posterior polar cataract. The cataract in the posterior pole, near the posterior capsule. In fact, that sits on the posterior capsule, and the chances of posterior capsule opening is almost very, very high. And you can't implant the lens inside the bag, and things become very difficult. There, this laser surgery is very, very effective to again make the chopping of the nucleus, opening of the capsule. Everything is done beforehand, and surgery becomes very simple. Now, this is one of our cases. You can see pre-fragmented nucleus pieces can be taken out very effectively without damaging the posterior capsule. So I think if you have listened me carefully, I've kept talking about posterior capsule because that's the membrane which is so important for making the lens put in a proper place so that you can see better. Because effective lens position is very critical for what is the refractive outcome after surgery. If your lens is not properly placed, the myopic lens little up, concave lens little up, little down, the power changes. So that is how it is so important to have an effective lens position in these cases also. Few things are important for refractive cataract surgery. Your cornea has to be properly mapped, and your biometry should be accurate. The optical biometry, which is also based on OCT, takes the measurement from epithelium to the fovea. This lens is so accurately measured, the error is 0.001%. Therefore, a biometry is accurate, a calculation of a lens power also becomes very, very accurate in these patients. The corneal power is also estimated in a very accurate manner so that we can get a good power. In difficult situations where cornea is not healthy, topography is very helpful in these cases also. Scanning the eyes before surgery is also very important. It tells you which type of cataract you are dealing with. And these innovations have made life simpler. Recently, we have shifted. I've been operating with 3D microscope for last more than a decade now. You people would have seen some of the ENT surgeons, other surgeons, you do a surgery through the microscope oculars. You see through the microscope ocular. Now we have shifted to a different way, where we are doing surgery in the screen, not through the microscope oculars. So this is what I do. So this is my 55-inch 4K screen, digital screen, and these are my polarized spectacles through which I can see the 3D image, the depth. So you have a beautiful depth perception. You can magnify the entire structure. Your surgical skill become better. And my neck and my position becomes stable. So you're not worried about your neck. So this is what happens to ophthalmic surgeons. They keep doing like this. They have a lot of neck and back problems. So this has been taken care of. And I'm seeing little 10 degrees away from my ear because my screen is like this. So I operate like this. So this is the new innovation which has come. It's good for surgeons. It's also good for teachers. Because my assistants, they all can see what I do in a 3D picture.
Your neck is so upright.
Thank you so much, sir. So this is a real benefit for this new innovation of microscope, which can be connected to a screen and gives you a digital picturization. And ultimately, these are things which are going to take you further in advancement in not only surgical technique, teaching and research also, sir. And these are few things which are also very important. The training for a young generation has to be done beforehand. So if you look at a bigger institution like AIMS, which I headed for quite a long time, so we have a training of a student in a wet lab, in a board side, in a simulators, and we certify them that they are now excel in all steps of surgery. Then only they can touch the human eye. So this has become a new way to make a training for almost every department of our surgical area now. Right from neurosurgery to our ENT to ophthalmic surgery. Everything is now based on a simulators. So this is a simulator. You can see the entire thing can be learned in a simulator like a video game. And this simulator gives you points. If you do a mistake, it will give a minus point. Accordingly, you have to improve every time. So definitely things are improved and you have a lot of safety also. This is a small video on the modern newer generation intraocular lenses. The surgery is improved, but the quality of vision has come because of a new generation intraocular lenses. And if both combine, you get a best vision out of this. So you can see here, I have cleaned everything. Now injecting the IOL from 2.2 of a lens which is 6 mm diameter and 12.5 mm length goes to the 2.2 mm. These are called foldable lenses. Goes inside, you can see it nicely placed. This is a trifocal lens. You'll see the rings and toric lens. The advantage of toric is if you have a toricity in the cornea, that can be corrected by these lenses. So effectively, you are not using glasses subsequently.
Toricity is cylinder. Cylinder part is toricity.
You can see here, these are toric marks, 3 dots, and this is the digital, scanning of cornea tells you where exactly you have to place the lens. So these are trifocal lenses. You can give multiple rings of a diffractive design, which gives you a multiple image with a single point. So this is the innovation on our intraocular lenses, which makes things better. And you can see I'm sitting here and doing my surgery through the digital video. So if I summarize the refractive cataract surgery, 3 things. One, it is the most common ophthalmic surgery done in adults. Second, It gives you a very faster rehabilitation. You can see very nicely next day. Some of my friends operate immediately next day also. My orthopedic surgeons, neurosurgeons, gastrosurgeons, ophthalmic surgeons, they all do surgeries. They can give you at least a practical dependence, which is desired for everybody, right from the young age to old age also. But most importantly, improved quality of vision, because we are correcting not only the error, we are correcting the aberrations also. And second, improved quality of life. यदि आपकी नज़र अच्छी है, तो जिंदगी भी अच्छी है. तो ये जो है कैटरेक्ट सर्जरी आपको बना के देता है. Another 5 minutes for another important area, that is refractive surgery.
सबके बच्चे अब ये लेसिंग को कराने के लिए तैयार है सर, तो इसको भी बता दीजिए.
थोड़ा सा मैं briefly जाऊँगा इसमें. Correction of a refractive error by surgery. This is normally done after you attain 18 years or plus, and when your refraction is stable and your eyes are healthy. And there are two surgeries. One is done on a cornea, and one is done near the lens. There are two refractive lenses in the apparatus of eye, which is like a camera. The front part is cornea, we all know that, which is around 43 diopters. The inner part is a natural lens, which is crystalline lens, which is around 16 diopters. So if you play with the cornea, you can correct much more. And if you play inside, like we do cataract surgery, we can replace the entire power. So LASIK is the surgery which is done over the cornea, and we can fit the lens inside the eye also, which is called phakic IOL surgery also. The entire journey of refractive surgery is almost more than 130 years old. But laser surgery has remained constant. It came around 1980s. The same laser is still being used with little modification, little software change, with better application, but still there. And that's why we know that these surgeries can be done. Myopia, up to large number, can be corrected by laser surgeries. Hyperopia, that is a plus power required, can also be corrected up to plus 6 diopters. And cylindrical power, almost 6 diopters. So large range of error can be corrected in these cases also. For LASIK, we have to make a flap on the cornea. That is around 100 to 120 micron flap. This can be made by either keratosis, which is a mechanical keratosis, runs with a speed more than 30,000 cuts per second, or a femtosecond laser. So this is a one small clips I've taken from one of my old surgery, because I don't do LASIK. This keratosis surgery now. So we cut after making cornea tight with the appellation pressure. With the keratosis we cut the flap. You can see I've already cut around 8.5 millimeter flap. It is lifted backwards. Then put the laser and get the flap back, reverse to the apply of the cornea. So you have corrected the refractive error by inside the eye, inside the flap in a stromal area.
So this is popular as blade assisted. This is the blade actually.
Yeah, it's a blade assisted surgery.
So blade काटने का मतलब है कि there can be problems with the blade if it doesn't run through, and that is why we've shifted to this robotic.
So this is a laser.
Popular name for this is robotic.
This is a femtosecond laser assisted surgery. We are making the flap with a femtosecond laser. Fast, accurate in terms of thickness, size, and it can also correct the decreases the aberration induced by making the flap. And surgery is very, very fast. You can see laser application. It is over within a minute. That surgery.
Great.
The second surgery, which has become very popular now for last almost 10 years or plus. Because 2016, the FDA approved this surgery, which is called SMILE. And this is a pocket base. We are not making flap. We are making a small pocket. Lasers makes the corrected lenticle inside, and that can be pulled out. So eye remains strong, safe, lifelong, and with a better surgical outcomes. And now we have a multiple devices where it makes the lenticle inside. Therefore, the new term is called as a keratofractive lenticule extraction, or KLEX. But SMILE is the mother of all surgeries as such. And the shifting to SMILE gives you 4 advantages. I think we need to know this, because the surface is not damaged in this. We are not making flag. The ocular surface remains healthy throughout the life. So you have a lesser dry eye related problems. Your nerve cuttings are less because cornea is one of the most populated tissue which is supplied by nerves in the body. It's a higher order aberration also. Refractive error is a lower order aberration. So this is a surgery which is, it takes hardly few minutes. This is a laser which is making lenticle inside for a smile. This is the inner side of cut. This is the cap which is being cut. It takes less than 30 seconds. In the older generation machine, the new generation machine, it takes less than 15 seconds. So in 15 seconds, the cap and lenticle is made, and it takes another few minutes to take out this lenticle.
So this is available at Agarwal?
Yes, we have. We have all the machines. All the machines.
Great.
I remember one patient coming to us from Saudi Arabia. He said, "Doctor, can you tell me why I went for a surgery in your place?" He said, "My idea was this is a new establishment, and new establishment will have everything new, modern. That's why I came to get a surgery done in your place." But he's correct also. So we have everything brand new, highly super specialized facility.
Yeah.
So this is the lenticle which has been taken out now. Very thin lenticle which ranges from 40 to around 70 microns only. It's very thin. It's like thinner than a sheet of paper. And surgery done in a very effective manner also. So this is what you see immediately after surgery. The cornea looks clear. Everything. If you dilate, see under the retination, you might see these cuts. This was the cap cut. This is a lenticle cut. This also disappears in next few months, and the vision improves greatly. And this is the OCT picture of a same eye. You can see this is the area where we handled. This is the area, but the cornea gets very clear subsequently also. So these were cases where cornea was normal, and you had a thickness to take out this lenticle from that cornea, because you can't go below a certain level of removal of this lenticle, because cornea should not be, the remaining cornea should not be less than 300 microns. So there's a limitation to how much you can carry. So if you have very high refractive error, how to manage that? There we do this surgery which is called phakic IOS. We are putting another lens underneath the pupil. This is called posterior chamber between the anterior capsule of the lens and the posterior part of the iris. So we have a space there. If this space is around 3 millimeters, then you can place this lens inside. You can see this is a lens. These are called phakic IOS. And it's very simple. These are various lenses which came in the past. Now we are all shifted to a surgery which is called either ICL, which is Star from a Swiss company, which is like this. It has the central optical area for a correction, and these are flanges which go behind the pupil, rest in the sulcus. And this is what you see here. This is a lens, this is the anterior capsule, and this is the cornea. And this space is required. Why? If the lens rests also, it touches the anterior capsule, you'll have a cataract formation. We don't want that. If it falls anteriorly, it can cause glaucoma. So these two things have to be managed. So this effective ball, you can see this ball should be around 500 microns, plus minus 200 microns. Sorry, I got hanged. I think that is
this is actually used for patients who have very high myopia or very thin cornea. Is that correct, sir?
Absolutely correct. Deven, how much we can correct the phakic IOS? थोड़ा मैं hang हो गया थोड़ा time.
14 के करीब तो सर आराम से कर देते हो.
चलो 14 भैया. Let's say anybody else?
Maybe more.
Dr. Saranya? 20 तक हो जाता है.
20 diopters myopia is extreme myopia.
Okay. If you are going for a Swiss-made star lenses, that can correct up to -18 myopia. But if you want more than that, then we have a beautiful Indian companies. They make lenses up to 25 diopters also.
What's a biotech, is it?
Biotech, IOCare, APA. We have a multiple company in India who make these lenses. India, in fact, is one of the largest supplier of lenses around the world. Intraocular lenses, like after cataract surgery, these lenses, and even the pharmacological medicines, India is now rising very fast. So Make in India is there in terms of our lens making. But in terms of machine, we are still struggling to come up to that stage. So this is a small video of how it goes. I think I'll just skip this. You have seen the surgery. So I'll summarize this refractive surgery for young people beyond the 18 years of age to correct. It is very precise and ultimate predictable. If I want to correct -9, it will correct -9. So the outcome in the post-operative plus minus 0.25. If I want excellent long-term outcomes, smile is a surgery in the cornea and phakic IOL ICL is inside the eye. Always people say this is a cosmetic surgery. I agree this is a cosmetic surgery because people get rid of glasses. But it has a huge therapeutic value, which we don't understand. You can imagine your child going with a thick glasses to school, they get bullied. They are psychologically depressed. And if you have a young girl to be married with spectacles, it's a social problem. So it has a social correction, psychological correction, as well as the cosmetic value also. So in fact, it's a therapeutic value. If your refractive error is more than 7 diopters, it is covered under the all the policies, insurance policies. If it's less than that, it may not be covered. So they have also understood that this is the therapeutic surgery for most people. So you can imagine refractive surgery is the life changer, game changer for all of us. And the outcomes are so beautiful, so predictable, so correct, only because the complications are negligible, very minimal. But we can understand if small complication happens to one person, for that person is 100%. For a physician, I will say, suppose somebody develops an infection, I say 1 in 40,000. For it's very remote. For that person, it's 100%. Therefore, these surgery require utmost care from our side in terms of looking into their feasibility, suitability of surgery. We do a lot of investigation before we say you are fit for surgery, which is so important for these young people who are doing this procedure. We don't take it lightly because it is this surgery in a normal life. We have a huge responsibility here. Thank you again for a kind listening. We can take the questions.
I think this is the most important thing in this. It's the ethical attitude of the doctor and the center which matters, because many centers reuse blades, and that is where it leads to complications. I know, sir, even if Agarwal wants to do it, sir will not let that happen. So I think that is something we can vouch for. Absolutely. Because Titiyal sir is heading. And Prabjot, you have to go to Dr. Arora. He has some questions for you. He's right there. Sir, Arora sir, आपके लिए सवाल. Puneet will be introduced by sir.
Welcome, Dr. Puneet. It's a very interesting topic, Oculoplasty.
Arora sir, injection.
जब तक लैपटॉप अटैच हो रहा तब तक मैं कुछ क्वेश्चन ही पूछ रहा हूँ लोगों से. Okay.
18 is the lowest, but higher age कितनी है? कब तक करा सकते हैं?
That's a terrific question. डॉक्टर साहब पूछ रहे हैं कि लीडिंग तो जो है लोअर लिमिट है, अपर लिमिट क्या है? अपर लिमिट नहीं है सर. It can be done for any age group, but yes, classically, after 40 years or so, you require near glasses. That is called presbyopia. To correct distance and near is very difficult sometimes. We do have a procedures, but the predictability and acceptability is little less in those group of cases. But we can correct their distance number. Suppose they have -5, -6. That's a handicap for more people. So we correct that so that they can only wear the near glasses. Or we make a monovision. One eye for distant, one eye for near. If they accept that, even that's a very good concept for people who do not want to wear glasses. Suppose somebody has undergone cataract surgery or some other surgery. They have a residual refractive error or they have some other refractive error. That can be corrected by these procedures. So age is no limit. But older the age, the response accuracy is a little different. Your calculation will change a little bit. They have more dry eyes, more problems. So that needs to be assessed. Okay, thank you for the question. I think Puneet should ready now.
We'll have a question answer session after the second talk. So please. So now we have Dr. Puneet Jain. He's MBBS from MNC, MD Ames, and a fellow of Oculoplasty from Hyderabad and from the New York Cancer Hospital. It's a very interesting topic, radio frequency machine-based oculoplasty surgeries. Let him elaborate on that. We'll have the question answer after the second talk.
A very good evening to everyone. I have had the pleasure of meeting a few fine gentlemen before also in one of the smaller CMEs. So good to be back. This is the other extreme of ophthalmology. So if there are 100 cataract patients, then probably there is one such patient which would need this procedure if adequately done. So we'll try to keep it. So I will show you 17 patients, 17 photos. That's all. Nothing else. Photos speak for themselves. That is what the beauty of plastic oncology is. Most of these tumors, lesions, they speak for themselves, and you really don't have to say much. So we'll start from outside to inside. So we'll start from the shutters of the eye, that is the eyelid tumors. So this patient, so all of these are either themselves medicos or somebody from medico family, and this gentleman was referred to me with a query of, it looks like a very suspicious kind of lesion. Everybody agrees? Looks fungating mass, lid margin not visible, was referred to me with a diagnosis of sebaceous gland carcinoma. I told the patient it will take 5 minutes, we'll take it off, we will not require any biopsy, because this is what a seborrheic keratosis looks like. It masquerades as sebaceous gland carcinoma. So the patient, extremely anxious, gentleman, 70 plus, medico himself, referred with a diagnosis of eyelid cancer. Imagine what is going through that patient's or that medico's mind. And it just took 10 minutes or 15 minutes, and this is how sir looks next day post-op. You can see that lid margin is absolutely okay, lid contour is unaffected. There's some ointment there, but absolutely okay. So this is where we've reached from probably 2 decades back, when all these procedures used to be looked upon as bloody surgeries. I'm sure you all have some concept of oculoplasty back from your, internship days, rotation in ophthalm department, where what I did, I'm a pastor from MAMC, so probably I can strike some chords with a lot of people in the audience. And all I did in internship was to take BP and fill consents. So for me, and I am from GNET, so I interned in GNET, it's one of the prestigious ophthalmological institutes. So what I'm saying is that sometimes telling such diagnosis to the patient without actually giving it 5 minutes can have a huge psychological impact on the patient. And see, the gentleman is absolutely 5 days later, 5 minutes later, 10 minutes give or take. Again, another fairy looking lesion referred to me as again sebaceous gland carcinoma. This is just seborrheic keratosis. This is how the gentleman looks 10 minutes later, thanks to the wonderful RF knife that we have. And if you see that even the lashes are intact. The slight edema on the eyelid is obviously because I have given local anesthesia to the patient. This is how it is. So this is how the patient is absolutely okay 15 minutes later. If the gentleman wants no bandage, I send off without any bandage also. These lesions are also very common. We let them go saying this is congenital, this has always been there, but you realize that this is touching the ocular surface. This is not a cosmetic surgery. It's a big nevus touching the entire ocular surface. And this is how the patient looks next day probably, because there is no edema, so it cannot be the 15-minute picture. But so you see the entire lid architecture is exactly the same. There is not even a single lash loss. And the patient is absolutely fine. Now the issue of doctor sahab kuch chubta hai, kuch feel ho raha hai, is all that is absolutely gone. These patients do not turn up for surgeries because they have been told somewhere that isko mat chidwao, kuch aankh ko ho jayega. It is like getting your tire puncture repaired. Nothing is going to happen to the engine. It's just here. Nothing is going to happen. So that's how far off we are from the eye. Now we go to a vascular tumor, big hanging, not a low hanging fruit, but yeah, kind of looks like. It's a big hemangioma. The gentleman was again living with it for quite some time because he was told that this is inoperable or would require a major surgery. You can see the CT scan. I will break it down for you. The tumor is sitting right on the levator muscle, which is the elevating muscle of the eyelid, which prevents ptosis or helps you lift the lid. I operated this gentleman. I'll show you some videos how this. So this is the RF knife, and this is how the dissection is. You can see the assistant is just holding a bud which is not even blood smeared, right? This is how this works. So it cuts and cauterizes at the same time. This is the latest in, at least in ocular oncology or oculoplasty as we speak. And this is how the tumor comes out. There is no bleeding whatsoever. It is a, remember, it is a hemangioma to begin with, and it's a large tumor, and this is how the tumor looks like. You can see my gloves. I haven't changed my gloves. These are the gloves that I used the entire surgery. Not even a drop of blood on the gloves. So this is how the patient looks immediately post-surgery. You can see there is no ptosis, which proves the point that fine dissection with the help of these machines can avoid any inadvertent damage to the surrounding structures. In this case, the levator muscle of the eyelid, which could have caused ptosis had we done a blunt dissection, which we all have seen. The blunt dissection with the scissors, pointing up and going. So 30 minutes, LA, no bandage to the patient, just ointment on the eyelid, and the patient can even see, watch TV or do whatever the patient wishes to. Have a drink also. I mean, that's okay. So another similar patient, vascular tumor operated. I've just put photos. This patient is operated somewhere. I think this patient was in Gorakhpur, operated in medical college, and you see that. Once you retract the lid, you can actually see the tumor coming out. My initial diagnosis was lymphoma, the eventual diagnosis was a hemangioma, but this looked like a lymphoma from the fornix. And this is how clean the dissection is. So I've just partially dissected the tumor. I'm still at the diagnosis of a lymphoma at this stage. And once I go further, then you see that that lobule that was protruding from the eyelid was this actually, this one, this portion. But it is a lobulated tumor. Again, this was a recurrent tumor, so I had to be very careful with the dissection, and this is how the entire tumor came out in one piece. You can't let these hemangiomas nick or rupture, otherwise it becomes an inoperable case, which probably might have happened. This is how the patient looks and operated under local anesthesia immediately after surgery. There is no bruising, no edema, no nothing. This is only and only possible with the help of use of these machines. This patient is unique in the sense that the patient traveled all the way from Fiji to get this big nevus operated, but without skin grafting. So the patient category is, doctor, I have met 20 people, including plastic surgeon, and they say that if I were to do this, you will have to take skin from retroauricular portion and implant, and there will be always some skin difference in the tone, but yes, you will get rid of this cosmetic blemish. It is actually involving the lid margin and the medial canthus also. This is how I open. Can you see that? I'm sorry about the contrast of the screen, but can you see the lesion is completely gone? I agreed to the demands of the patient, and I bandaged the patient with paraffin dressing every alternate day for 7 days to allow granulation tissue to happen. You would understand that if this were to scar, then the patient would have a very bad ectropion. So for a cosmetic procedure, the patient would have a functional issue for entire life. Middle-aged females, 35-40 probably, right? And this is her picture she sent from me on WhatsApp, so that's why it's a slightly poor quality picture. Do you see any scarring anywhere? Any ectropion? Any closure? So these are very tailor-made surgeries. This is not possible with blunt tissue dissection without the use of these machines. So she sent me this over WhatsApp. This probably is about 2 months down the line when the entire surface is epithelialized. There is not even a bit of skin tone difference. Had I chosen skin grafting for this patient, or somebody else would have done it, there would have been a big light colored patch. So in place of a dark colored patch, she would have a light colored patch lifelong. Cosmetic blemish again. So this is where we've reached when it comes to, so we'll now go quickly touch surface tumors also. This is a very typical conjunctival squamous neoplasm, very commonly seen in practice, more common in farmers. We see it very often, and this is how the patient looked 20 minutes later. The highlight of this surgery is that I do not give any peribulbar anesthesia or any local anesthesia. I just use drops like the cataract surgeons do. The assistant keeps putting a drop. The surgery takes about 20 minutes. and the tumor is completely gone. This is a larger tumor. This is how the tumor heals. So you remove this tumor, you put an amniotic membrane which is obtained from the placenta. This is a fresh amniotic membrane. This is how the amniotic membrane dissolves, leaving behind an absolutely clear limbus without any scarring. You can see such large lesions also respond very well without any scarring. So this completes half of the PPT. We are at patient 10. You also see patients like this, often referred with lipoma. This is just fat finding its way out. So you can see the gentleman has a lot of lower lid fat prolapse, upper lid fat prolapse, and also subconjunctival fat prolapse. These surgeries are also done with RF, so we just give a nick here, we lift this, we find the tissue planes as we did in other patients, and we just paste back the conjunctiva with glue. Again, the highlight would be that there is no injection involved in this. The patient just has to look into the light, and in 20 minutes the patient is absolutely looking. So huge difference, not just in the appearance of the patient, but a huge difference in the overall ocular surface, because this patient was having an extremely bad time with watering in the eye. The cause of watering was those two bilobed tumors which was causing an uneven ocular surface, and you can actually appreciate in the picture also there is no watering in the next slide. Now we come to the last bit, which is the orbital tumor. So when somebody talks about orbit and tumor, these are the things that come to mind. I'm sure they come in mind of Dr. Titiyal also. From the Cmes Oculoplasty department, बहुत सारा खून बहेगा, 7 दिन हॉस्पिटल में रहना पड़ेगा, कोई सर्जिकल ड्रेन तो पड़ा होगा जो कान के पीछे बंधा होगा, बहुत टाइम लगेगा हील होने में, पेशेंट को बताना पड़ेगा, सूजन रहेगा, रोज किसी को बैंडेज करना पड़ेगा, और बहुत सारे पोस्ट ऑपरेटिव रिस्ट्रिक्शंस होंगे, ये नहीं करना, वो नहीं करना, कुछ नहीं होगा. Now, so we'll go. So this is a patient. My diagnosis for this patient was a dermoid cyst. I'm sure quite a few know that these are congenital lesions if this were a dermoid, but he presented with a history much later, 45-year-old gentleman with a history of about 5-6 years, neglected it and came to me like this. Obviously a very bad looking tumor with a lot of orbital extension also. So we planned the surgery. So this is done with just one assistant, no multiple assistants required, and this is how the entire tumor comes out. So for reference, the average axial length of the eyeball is about 25 millimeters. So this is 30% larger than an average size of an eyeball, right? And this is how the patient looks at suture removal day 6. There is no swelling, almost no scarring, very subtle ptosis, which is obviously because the patient is still healing, and absolutely fine. No hospital stay, daycare surgery, 1 hour under general anesthesia. Of course, you cannot do this surgery in local, because then you will never be able to satisfy the patient. Patient will be wincing in pain during the surgery. Another patient, you can see there is a huge proptosis. This is a worm's eye view. You can see the left eyeball is much anterior. This patient is, by the way, from Iraq. Had a surgery previously, and the histopathological diagnosis was some random osteofibromyo something. Whatever tissue you can think of was mentioned in the biopsy report. Osteobone, myo, fibro. These tumors don't exist in the orbit, so we knew that something is off. We went for a CT, and you see that the lesion is stuck to the optic nerve all along. It's a huge tumor. The eyeball looks absolutely negligible with respect to it. The patient's vision was 6/6. We operate this patient. So again, very neat dissection, and this is what came out. This was all behind the eyeball, next to the optic nerve, clinging to it. So in these cases, we use a cryoprobe, as you can see in this picture, which acts as a third hand and which helps in tumor delivery by a wriggling motion. This is how the surgery was closed. So again, no swelling, no ecchymosis, sub-brow incision, probably no scarring, right? This is how the patient looks the next day. I am in a ethnic attire because this surgery was done on Dhanteras, so the next day there was something in the hospital. The patient was 6/6. I did not admit the patient. The patient was operated, started surgery at 2 o'clock, 2.5 hours surgery, it takes time. And then the patient was discharged 3 hours later as per the instructions of the anesthetist for observation. Patient went home, slept well in his hotel room, came the next day. I told him to get sutures removed in his country, and patient flew out. The patient is happy. Next day you can see there's some ptosis. Obviously there's some edema post-operatively, but the vision is 6/6. and the tumor is completely removed in one piece. Again, an hemangioma, if these tumors get even the slightest of zynics, you have to abandon the surgery and the patient lands up where he or she was, and there is a very high chance of loss of vision. So this is where we have reached with respect to orbit. Okay, so everybody knows what is a chalazion in the eyelid. Looks like a chalazion, very characteristic chalazion. आप लोगों में से कहीं ने इनको ट्रीट भी किया होगा व्हाट्सएप पे, गरम सिकाई कर लो, 1 मिनट लगा लो. True, agreed? किसी ने तो किया होगा. ठीक. So when we evert the eyelid, you see this is a chalazion, of course. It's a sebaceous gland carcinoma. It is adorned the entire lid. He is the Uber driver. He has got his chalazion incision and curettage twice. Probably somebody never everted the lid or never cared. I don't know what procedure was done, but he had records elsewhere. So in these cases, obviously it's a carcinoma, it's a bad carcinoma which is locally invasive, doesn't spread in the body, just to the lymph nodes. This is what is the intra-op status of the patient after removal of the tumor. So 2/3 of the eyelid is gone, but the patient did not want an eyelid shearing procedure. So in these cases, what we usually do is we take tissue from the lower lid, we extrapolate it to the upper lid, the eye remains closed for 6 weeks, and then we cut and we separate the lid. It's called a lid shearing procedure. The patient cannot see for 6 weeks. Just a couple of slides. अगर सब लोग बोर हो रहे हैं तो मैं वाइंड अप करूंगा, नहीं तो so I have the permission of the audience. So because the patient wanted this, so I did tensile flap, release tissue from the canthus, and did a non-lid shearing procedure. This is how the patient looks. So look at the lashes in the center of the eyelid. Where did they come from? They came from the extraposition of the lateral half of the lid. So now the patient could obviously go to his. I did not ask the patient to, take a leave from the work, but the suture removal happened at day 8. So day 1 week I asked him to rest, but then he could drive. And this is how he looks probably 4 weeks later when everything is sealed off. So again, possible because of meticulous dissection, possible because of use of certain advanced machine which probably were not. Last bit purely cosmetic, but of keen interest and a lot of patients in the audience as well. Maybe you can relate, and we can talk in hush-hush tones over dinner. So this is a typical case of dermatocalasis, drooping of excess upper lid skin. Now again there are a lot of misconceptions about this surgery. किससे कराना चाहिए? Dermatologist से कराना चाहिए, plastic surgeon से कराना चाहिए, या Oculoplasty surgeon से कराना चाहिए. अब eyelid हमारा डिपार्टमेंट है तो हमारे से कराना चाहिए. But that's not a good sales pitch, right? So look at this gentleman, absolutely unrecognizable. I always ask all my patients to get their passport photos changed because they will look unrecognizable after the surgery. This is exactly after 20 minutes or 30 minutes maybe, not more than that. Local anesthesia, you can see a nice suture going. This is intraoperative picture. Nice suture going in. This suture is required to give that lid crease scarring. Otherwise, the lid will look stretched and artificial. Older patients, they think it is a cosmetic condition. No, it is a functional condition. The skin is hanging, obscuring half of your visual field. The patient has 6/6 vision. But how? After reading like this. What is the vision like this? So, क्या फर्क पड़ता है? So, perfect 6/6 vision, both eyes cataract operated. But can the patient use her vision? No. And how does the patient look after a week? No, next day, this is next day, the suture is still there. You can see some swelling here, the suture is still there. Again another patient, some hospital HOD's mother. So, absolutely normal. This is intraoperative picture again, so there is some swelling because of the block. The aspect ratio of this slide is not good. It looks like an owl eye, but trust me, it is a normal eye. So this is how the patient looks. So imagine going from this to this in less than an hour. This is what lower lid blepharoplasty is about. We do it transconjunctivally, meaning going through the conjunctiva without any skin incision, and we try to give a very natural appearance. So 40-year-old gentleman looking like a 60-year-old gentleman, and then back to 40. This is how the fat bags look once they are removed. These two surgeries now blepharoplasty upper lid and blepharoplasty lower lid are very commonly performed, especially post-COVID, because patients, I presume that the patients are more conscious about how they look and how they feel. So how they look comes directly into cosmetic domain, which is blepharoplasty.
किसी ने भी खाना नहीं खाया. Please join us here. Dr. Tulsi, are you ready with your questions?
बेटा लाइट ऑन करके से
Or you want to wind up?
Yeah, we have some questions to Dr. Titiyal. We have a mic here. We have a mic, extra mic. That's what your mic says. So, to begin with, let me say that was a masterful talk by you, sir. So, let's talk a little about the robotic cataract surgery versus the conventional surgeries. Is it still in early clinical trials, or you're doing it regularly?
It's a regular feature. In fact, this is a well-established procedure for almost now more than 2 decades. In India, it came in 2008, so almost 18 years. In West, it is there for almost 25 years. So it is, in fact, in most of the Western countries, this is the primary method of surgery. India, because there's a cost, if given the option, if there's no cost, I'll do every surgery with this.
So, how much is the cost difference?
It adds around maybe from 25% more.
25% worth it, because being more precise and accurate. But basically, the surgeon, a surgeon like you, who is in charge of this procedure, the robot is just a stabilizer. See, and such a reputed surgeon like you probably would not, you look so young, you don't have any tremors in your hands, why would you need a robot?
I always give an answer in a different manner. Like, suppose there are 4 females gone for purchasing sari. Somebody purchased from a Chandni Chowk, same sari. Somebody purchased from a South Action Mart, Part 2, same sari. The confidence is different. The person comes out, said, I've got a robotic surgery. The outcome is same. So that's the confidence inside them, okay. That is how it
Outcome is same. So let me also talk to you about, it's not for everyone. You see, especially if you have a corneal scar or an opacity, probably, and pupils which would not dilate. See, can you do that?
We can still do it, but there has to be some more technique involved in that. We have a pupil expanders also, which can be put inside the eye and then you can apply the laser. But if your opacity is huge, where laser cannot penetrate, then you cannot do it. And as such, cataract surgery, general surgery, routine surgery also becomes difficult in those cases. But if you have mild opacity, you may still do it.
The capsule can tear, and then the robot is not going to fix it. This is Dr. Titiyal who has to fix it.
Definitely. Even after the laser application, it is the surgeon who is going to take care of those areas which may not be, laser has not touched that area. You're absolutely correct.
So finally, my last question would be regarding, there's a lot of buzz regarding which lens is the best. There's no one best lens. Talk us about the various lenses that you have today.
Okay, I think, if I summarize, there are, at present there are 3 types of lenses, grossly. One is the monofocal lens, which gives you a very clear vision, and for reading you require glasses 100% time. And second category is we call EDOF lenses. Those are extended depth of focus lenses. That gives you freedom from glasses most time for distance and intermediate, which is the most required nowadays. The EDOF lenses are the lenses for a present time, for people who are distant. Third is the trifocal lenses, where you have focus for a distance, intermediate and near also.
Is that a multifocal lens?
Multifocal. Multifocal become now trifocal.
Okay.
So you have bifocal and trifocal. So in fact, there's one question we asked to begin with. Okay, what is your profession? what is your daily activity? The first question, if you are a driver, you drive in the night time, then most likely multifocal should be avoided in those cases because light will give you rings, halos, glare. So that should be avoided. If you say I'm not driving, I'm just at home, I read, then trifocal is good for those people.
Right.
But if you're an active person, young person, age group between 45 to 70, then EDOF lenses are best. And the second most important thing is the associated ocular pathologies. You are a diabetic patient, has a diabetic retinopathy, you have an age-related macular degeneration, or you are a glaucoma person, then multifocals are no for this. Only monofocal lenses or little bit towards the EDOF lens.
Right. So as Dr. Chauhan said, on our 1000 CME, probably like to invite you on diabetic eye diseases.
Yes.
Thank you, sir.
So along with me, Dr. Prabjot.
Yeah, we know Prabjot.
Yeah.
He's there. Yeah.
Busy, yes. Two, three calls.
I know. Thank you, sir.
Sir, Dr. Kalra here.
Yes.
Sir. Only 2.5 questions, sir. Very recently, there was a post about insulin eye drops. So, what is the role? And is the eye drop better or ointment?
Okay. I think it's a very new thing which has come in our practice now because insulin has a very nice growth factor for tissue regeneration. And it is being used for cases where you have the epithelial defect, where epithelium is not healing, especially after chemical injuries or insult with some other injuries, and especially neuropathic disorder where you are, because patient doesn't have a sensation that the epithelium not growing. There we have found that insulin drops are very helpful in improving the rapidity of epithelial growth in this case. Because of epithelial growth factor is there in insulin drops. Ointment is yet to be established in the most of the time. Drops are very, very effective in some cases, not all cases, some cases.
Just a corollary to that, is there any role of hyperbaric oxygen also? Is it used?
Sometimes yes.
Sir, presbyopia surgery, are you doing it?
We do for us some cases, not for every case like other refractive error. As I said, it does have a limitations.
About redo surgery, is there any case you are doing for those who have failed with others? Are you correcting them?
I think that's a wonderful question. Any surgery which we do should have the option for a redoing also. If my machine doesn't permit me to redo the surgery, it's not a good machine. So whatever machine we have, it gives an opportunity to redo also. Suppose I do LASIK in some patient, I can lift the flap again any time in life and reapply the laser if the thickness permits. Similarly, spine surgery, then also the cap I have made, I can make it a flap again. The machine gives that software. So any machine which gives these options should be the good machine. Yes, re-application of laser can be done for most cases.
So my last comment, eyesight and vision, they are interchangeably used. I think you have done both for our Modi Prime Minister.
That's absolutely correct. Vision is different and visual acuity is different. Acuity will be measured by somebody's ability to read certain things. My vision is a composite thing which includes your acuity, your quality of vision, contrast, which is so important. You can read 6:6. I can read 6:6, you can read 6:6, but contrast will be different. If I can read at a 10 meter distance 6:6, maybe I can't read 6 meters. So my acuity is 6:6. So that is the contrast. So anything which improves the contrast is the quality of vision which you want.
Sir, Dr. MPS Gandhi.
Yes, sir.
Sir, I know one particular case where when the lens was implanted, it was folded, It was not straightened up and there was no vision. So obviously there will not be any vision in that particular eye if it has not been cleared. It was like this kind of a thing. So in that case, what is to be done and till how long you will do it and what next to be done?
Normally all these foldable lenses, they unfold slowly sometimes. Some lenses open immediately, some lenses open slightly slowly. But sometimes it has two things. One is the central optics and two arms. Those are called haptic. So the haptic is attached to the optic, then it doesn't come out. Your lens will be, little decentered because one area is not been fixed. Only one area is fixed. So this decentration will cause a lot of refractive error because the tilt and the position, as I said, can change the outcome in these cases. But if picked up early, it can be redone. I can go again inside the optic theater, open the haptic optic junction by little traction to be given in that area. It can be redone.
Can be redone?
Yeah, unless there is a, as I said, deficient posterior capsule, the vitreous is coming up, lens is tilted because of that, then I'll have to take the lens out, clean the vitreous, put another lens in a different area. The second area of putting lens is the sulcus. Over the anterior capsule which is open. So it goes to sulcus and remains stable also.
What about dialing? There is something called dialing also in it. They sweep it and it comes out in normal position.
The dialing is done when your lens is not oriented correctly, especially in cases where you have put a toric lens. I wanted my lens to be 100 degree. My lens is now in a 90 degree. I can dial and rotate to the same areas. Or the one of the haptic is in the anteriorly, one is into the bag. Then we will dial the haptic inside the bag. So that are few situations where dialing can help.
It happened to my right eye. But after dialing it came out to be okay.
That must have been one haptic must be over the anterior axis, one inside. Then dialing helps.
And how much is the cost of that LASIK surgery at your place, which you said 18 years plus can get it done?
Yeah. It ranges from around if we are doing a femtosecond laser for all patients, it's a 90,000 to 1.4 is the range for both eyes.
Thank you.
Mine was you had put toric in left eye. Right was plain.
Because your left eye would have had a sub-cylindrical power. And it is very important. If I'm putting a premium lens in your eye, the toric has to be corrected. Otherwise, you don't get a value.
And you did femto.
Yes. You had a most advanced Thank you.
Dr. Titiyal sir, as a physician, my knowledge about ophthalmology is the lowest. In fact, sir, Dr. Alaprashan would remember our ophthalmology viva was taken by the HOD of ENT, Dr. Kakkad, because we were so poor in ophthalmology. And sir, सर डॉक्टर कक्कड़ ने डॉक्टर AK गुप्ता के सामने में हमारा वाइवा लिया ऑप्थेल्मोलॉजी का और उन्होंने कहा मैंने पूछ लिया बच्चे बढ़िया फर्स्ट क्लास है कोई दिक्कत नहीं तो सर हमारी ऑप्थेल्मोलॉजी की नॉलेज बहुत ही पुअर है इसलिए मैं आपसे सर एक सवाल बिलो पॉवर्टी लाइन पूछ रहा हूँ माफ कर दीजिएगा अगर अच्छा ना लगे सर एक लेजिक में कस्टमाइज्ड लेजिक सर्जरी कहते हैं सर व्हाट इज कस्टमाइजेशन
ओके So before I answer this question for my friends from PFI, certain things are important. In general, one is routine eye examination. Patient coming to you, which are those people where you should ask them to get an eye checkup done? First thing, a family history of eye disease. You have to get an eye test in that. A person who is wearing spectacles, you get your eye checkup done. Person who is suffering from various systemic disorders must get eye checkup done. Diabetes are very common in that. But sometimes we miss that. And checkup done at the right time, you can save the eye in those cases also. Because we can diagnose, looking at the eye, almost everything which is happening in the body today. In fact, Google has taken the thing. They can predict what's going to happen after 50 years in your body.
Even after that.
Especially Alzheimer's. So this retinal vascular areas, the structure of our retina is going to predict so many things. So you people have to be very careful, make sure they get eye checkup done. In fact, we have picked up many tumors in the brain by just looking at the eye and we save the person. When they come to eye doctor first, they have some visual disturbance. This is so important. As far as customization is concerned, it is done. Customization can be done in IOS cataract surgery also, for refractive surgery, laser-based surgery also. Especially those cases where they have a slightly more higher order condition, like minus power, myopia, hyperopia, astigmatism, they are called a lower order condition. That's corrected by any machine. The first customization is the asphericity, because our eye has a positive spherical aberration, and that causes the light which is coming from infinity doesn't focus to one. The peripheral part of spherical lens focuses little anteriorly, center part focuses little posteriorly. So you have a huge, area of circle of diffusion. Therefore, you can't see clearly. Aspheric lenses make sure that all the rays focus to one point. So that is first customization. Second customization, you have a higher order aberration, which you call coma, trefoil, which are mainly on cornea. That can also be corrected by laser. So these are called customized products.
So does it cost more?
Little more. Those should not cost more. In many places they don't charge much, because marketing has to go to different levels. So they put a cost for every new step.
In your setup, if somebody asks for a customized LASIK,
You don't charge extra.
you don't charge extra.
Same cost.
Right, sir. And I understood that it's about 1.5 lakhs maximum.
Yeah.
Is it, sir?
Sir, most good centers don't charge extra.
No, I just wanted to ask, sir.
Because one clarity I want to give. In between there was a thing called contour vision correction. So it is nothing different. It's a LASIK procedure. Only thing is you have a new software in the machine to look into a higher order aberration and correct that few laser more spots. And people thought this is a different surgery and different instrument, and they were charging more for this.
Sir, I have heard that you are a very good singer.
Yeah, not at all.
किसी ने बताया था, sir?
Titiyal sir, Johan sir is a very good.
No, I am not.
मुझे पता है,
I am not.
मुझे पता है पिछली बार ही आपने गाया था।
नहीं। सर, मुझे डॉक्टर देवेन ने बोला कि सर से गाना गवाना है, तेरी आंखों के सिवा दुनिया में रखा क्या? सर, दो लाइन।
बहुत मेरे बस की बात नहीं। आज का फोरम कारण
डॉक्टर जैन,
ये गाएगा।
wonderful.
सर पूछ रहे हैं OCTA।
Yeah. Your hearing also is so good. So talk us about the OCTA in diagnosing coronary artery disease by looking at the retinal vessels.
ये हमारी लड़की आ गई भैया, प्रभुत्व कहाँ जा रही है?
मैं तो इस बार सर से दूर हो रही थी, इस बार मेरा नंबर नहीं है।
You're going to talk
और
about
लाइटर
सर पूछ रहे हैं कि OCTA का क्या यूज है?
in diagnosing early coronary artery disease by looking at the retinal vessels. Talk us about this.
So, early movements in coronary artery disease, mostly really hypoxia and the differentiation of the blood supply to the retina. One might see some capillary pruning of the vessels and all early changes on Gupta, but we do not have, it does not have any practical relevance as of now, sir.
I believe if it is done, you can diagnose early coronary artery disease by looking at the retinal vessels.
Yes, I think.
Vascular aspect.
A lot of times we do, not exactly coronary artery disease, but we do see some attenuated vessels that is we should check that BPL.
I'm referring to the recent article published in JAMA 2026. Thank you.
आप सही कह रहे हैं सर, with the AI based things now, what is happening, they have this series of millions of retinal vasculature, and they are correlating with the coronary artery disease in these cases, and that can predict.
By using AI, that's
Yeah.
rightly said. Thank you.
Thank you, Dr. Titiyal, sir. Thank you, Dr. Prabjot, and thank you, Dr. Jain, for a wonderful presentation. Thank you, marketing, Mr. Bhardwaj and Mr. Manmohan. I would request all of you to please come for a group photograph.
Oh, yeah.
Dr.